Hello and welcome to the module Immersion in Water for Labour and Birth, Evidence into Practice. Water birth is a key element of our midwifery practice, but despite this, the uptake of water birth throughout the United Kingdom and internationally remains sporadic. In the year 2000, the RCM carried out a survey which found that only 50% of units offered a water birth facility in the form of a pool within their unit. In 2017, that has now increased to around 60% of units offering a water birth facility for their women. The NICE guidance, National Institute of Clinical Excellence, in 2007 and updated again in 2014, recommended that women who have low risk or uncomplicated pregnancies have access to the use of water birth facilities. As the use of water is a fundamental midwifery skill, it is essential that as midwives we understand the underpinning of the research which supports our practice, and also understanding the basic clinical skills that go along with supporting women who choose to labour in water and then go on to give birth in the pool. This is the first of two modules which covers the key aspects of the use of water in labour and birth. It is recommended that both modules are completed to gain a holistic perspective of water birth in the current context of midwifery practice. So the aims and the objectives for this module are to show you an understanding of the use of the water for labour and birth, an overview of mothers' experiences when using water for labour and birth, how to create a birthing space for women where she and her needs are central to our care delivery, and considerations and practical midwifery skills to support water birth through the 3 stages of labour. There's a significant amount of research which supports the use of water in labour and birth. Within the United Kingdom, NICE guidance and the Cochrane Review support the use of water as an effective method of pain relief without any increase of risk to the mother or baby of infection or any other adverse outcomes. The Cochrane Review in 2009 found that the use of water showed a significant reduction in the use of epidural analgesia by women. Mothers themselves have shown to experience less pain and an increased satisfaction with their birth experience when labouring and/or giving birth in water. Now that we've reviewed the research that underpins the use for water in labour, let's have a look at the physiology of women who choose to labour in the water. The physiology of labouring in water is underpinned by a very complex cocktail of hormones. Immersion in water sets off a cascade of hormones, and this begins after only 30 minutes of being in the water. Blood is redistributed, and this triggers a release of a peptide known as ANP, by specialised heart cells. This release, along with the other posterior pituitary gland, work together to release lots more oxytocin. Therapeutic touch of water on the skin also increases oxytocin and endorphins. The oxytocin release is thought to peak at about 2 hours after being in water immersion, but the RCM does not recommend placing any time limits on women entering or exiting the pool. There is much debate about the timing of pool entry when a woman is in labour. It has been suggested that the optimal time should be around 5 centimetres before entering the pool. However, women's choice should not be overridden at any time, and women may enter and exit the pool at any stage of her labour. If contractions are not increasing or have decreased within 30 minutes of being in the pool, discuss with the woman and have her try some time out of the pool, mobilising in a position that she finds comfortable. She can re-enter the pool at any time if it is still safe to do so. Now that we've had a look at the physiology which underpins the use for water in labour and birth, let's have a look at the criteria for using the pool and creating an environment for both labour and birth. Each unit will develop its own guidelines around eligibility criteria for the use of pool for labour and/or birth. But generally, the criteria is a singleton pregnancy, a term baby, which is between 37 weeks and 42 weeks, and a cephalic presentation with no medical or obstetric complications. Women with additional risk factors may request a pool for labour and birth, and these should be discussed with her and a plan made, and we'll discuss more of these at the end of the module. Now that there is an understanding of the evidence which supports the use of water in labour and birth, we must examine the birth environment and how it is essential that women and their choices are central to our care delivery. Creating an environment for women where hydrotherapy or water birth can be a realistic option and are achievable in almost every unit, regardless of whether there is a purpose-built pool facility. Practically, your unit can identify a champion for water birth. They would ideally be available to support and facilitate other midwives in their learning and development of water birth skills. And from this, more midwives can gain confidence in their skills, facilitate more use of water, and so on and so forth, and they themselves then becoming champions. So what is needed to create a space? The pool room in some labour wards can simply be a pool within an obstetric equipped room. To create a peaceful space, remove any unneeded equipment, push the bed to the side so it is not central in the room if one happens to be in the room, dim the lights and close the curtains, offer music where possible and of the woman's choice. Calm and quiet voices. Perhaps you might want to think about placing a sign on the door saying "Do not disturb" or "Please knock before entering." It may be worth taking a tour of a local birth centre to see how they are creating a space for their women where water is a central feature. If your unit does not have a pool, you can still facilitate the use of water by offering the woman a bath, lowering the lights if requested, and using flashlights in the room to create a mood. Now that we've reviewed the criteria for using water in labour and birth, and have also had a look at how to create a positive birthing environment for women, let's have a look at how we can support women with practical skills through all 3 stages of labour. It is essential to think about how you're going to fill up the pool to support a woman in the pool. When filling up the water, it is essential to remember to fill it up to approximately the level of the breasts. This is to ensure that the water is not too full and that a woman becomes unstable in the pool and unable to support herself. If you have too little, this may reduce the pain relief effect of her being immersed in the water. Women can get in and out of the pool by sitting on the side and swinging her legs over and then immersing herself slowly into the water when she is ready. Some women may require a small stool or platform to reach the rim comfortably, and she may need some support to move her legs over. Either partners or midwives can do this. When in the pool, women can adopt whatever position is the most comfortable. The weightlessness of the pool will support her in accessing a variety of upright and comfortable positions. Pools should be heated to approximately 37 to 37.5 degrees Celsius to prevent the mother from becoming too hot. Please be aware of the ambient room temperature because the differential between the two can make the woman quite uncomfortable. You do not want the room to be too hot or too cold. Women may choose to labour in the pool naked, or they may opt for swimming wear or some religious clothing. This should be the woman's choice, but discuss with the woman about having visibility when the head is beginning to emerge, should she have chosen to stay in the pool for birth. Women should be encouraged to drink and snack while in the pool, drinking anything of their choice and eating anything that they wish. You should also ensure that women void regularly. Partners may opt to enter the pool, but you will need to follow your local infection control policies when supporting this. However, it is a very intimate and personal experience for many families, and partners may find this something that they wish to do. Their choices should be supported where possible. Observations in labour are critical. You'll need to monitor and record in the notes some of the following. The ones of particular interest during water birth is hourly pool temperatures and hourly maternal temperature to ensure that the pool is remaining within the parameters that are set by the NICE guidance and local protocols, and also hourly maternal temperature to make sure the mother is not too hot or too cold. You should follow all the guidelines of your local trust when carrying out any other observations on mother and baby. There's no evidence to support leaving the pool for vaginal examination. However, you need to consider your posture and the comfort of the woman at this time. Gas and air can be used while women are in the pool, but close monitoring is required to ensure she remains safe and able to move effectively around the pool and exiting the pool should she need to. Please consult your local guidelines when a woman has had any opiates and wishes to labour in the pool. Women with epidurals cannot get into the pool, even if the mobile epidural is in situ. Some women may feel that they wish to leave the pool at this time. If this is their personal preference, they should be supported, even if they have previously expressed the wish to have a water birth. Should a woman wish to remain in the pool for the birth, you should continue with the observations of maternal and fetal well-being as outlined by your local guidance. You can use a mirror to watch the head for fetal descent, and women and partners may wish to see this too, so please remember to offer. Once the baby is born, the midwife or partner gently brings the baby to the surface, head first, taking about 3 to 4 seconds to do so. Do not pull on the cord. Give the mother to the baby. The body of the baby should be skin to skin and be submerged to prevent the baby from becoming too cold. remember to ensure that the baby's face should remain out of the pool at all times. Delayed cord clamping is now encouraged nationally to permit the hemoglobin and stem cells transfer to the neonate. When the family is ready for the cord to be cut, offer to the partner or the mother to do so if they wish. Mother and midwife should have discussed whether there will be a physiological or actively managed third stage. There is limited evidence on the third stage of labour in the pool, however, this should not override a woman's preference. Some women, therefore, may wish to remain in the pool for the birth of her placenta. For active management of the third stage, intramuscular injection of oxytocin has traditionally been in the leg, which is hindered when in immersion in the pool. Although limited evidence, some units will ask women to leave the pool for the third stage, and others offer intramuscular injection in the deltoid as an alternative. Please see your local practice guidelines. It is essential that you monitor the pool water, observing whether there is an increased darkening of the pool, indicating blood loss. If you are concerned at any time, ask the mother to leave the pool. Blood loss in water births can only ever be estimated. Women can leave the pool the same way that she entered. It will be challenging for her to do this when holding a baby, so this may be an optimal time for the partner to have some skin to skin as you help the mother out of the pool. Now that we have reviewed the practical skills used to support women throughout the 3 stages of labour, let's have a look at some of the most common requests that women may have who do not meet criteria. Each hospital will create guidelines that should support you when working with women who've requested a pool for labour or birth and do not meet criteria. In this section, we will look at some of the most common conditions that women may have who may ask to use a pool. It is important to remember to work with women to give them honest, unbiased information about their risks and let them choose where and how they wish to give birth. Women with an increased body mass index. Key factors to consider is her mobility. Can she get in and out of the pool safely? A vast majority of women can get in and out of the pool with ease, regardless of their BMI. Having an operational policy which looks at how to summon help when needed. This will need to be considered when removal from the pool is required if a mother collapses. And also consider how to monitor the fetal heart rate during labour. As many women find mobility in the pool easier than they do on land, women will adopt positions which will make listening to the fetal heart easier as if needed. As with any situation, if you are unable to hear the fetal heart rate properly in the pool, ask the mother to either change position again or get out of the pool until a normal fetal heart rate can be established. VBAC or vaginal birth after cesarean. If no other increased risk factors, mother with VBAC should be offered the pool for labour and, if she chooses, birth. Continuous monitoring is the current recommendation by NICE guidance, and wireless telemetry is often available in units, and this can afford the mother to be in the pool whilst continuous monitoring is taking place. Antibiotics can be administered in the pool as long as the IV access is wrapped cleanly and remains out of the pool. Some units may adopt for the mothers to leave the pool for IV antibiotics and have the IV site removed in between administrations. Please consult your local policy to see what you can do to support women who are GBS positive with water in labour and birth.